So the next scenario we're going to talk about is the theme of microbiology, and the story consists of two patients this time. So a 55-year-old lady and a 54-year-old lady who have both been referred into the acute medical unit of their hospital, both sent in by different GPs, but they have a similar suspected diagnosis of sepsis. So they are both seen, they're very similar in age, and they've literally got a date of birth that is exactly the same year, just a month difference in their date of birth. So they're seen by the same junior doctor who follows the correct protocols of taking history, doing an examination, and takes some blood cultures because they're suspected sepsis. They've got a temperature and showing other features that will be consistent with that. The difference between them is that one of the patients is suspected of having urosepsis, and the other is suspected of having an underlying pneumonia, so a chest cause for the sepsis as well. So these blood cultures are sent to the microbiology lab, and they're booked in as by the normal processes, and plates are prepared for them. But a mistake happens in that the wrong label of the wrong patient is put on the wrong plate. And so the results come back, and the patient who has the respiratory cause, in fact, is said to have an E. coli growing in the culture, when the other patient has Streptococcus pneumoniae, and which is not what was expected for a urosepsis patient. And it is then the consultant who then reviews these results that queries this, because it's Streptococcus pneumoniae is an extremely rare cause of a urosepsis, questions that, and then going back down the chain, they identify the error that's been made by looking at the original request forms and the information. Now, the outcome of this is that the right information eventually was reported to the treating clinicians, but you can imagine what would have happened if that wrong information had been communicated. The patients could have ended up on the wrong antibiotics, and particularly for things like sepsis, where we've already got a significant mortality and morbidity associated with it. The outcome could have been a lot worse if you're on the wrong treatment for the wrong infection. So why do we think this happened in this sort of situation?
You can think it's probably time pressure, because with the how busy the laboratories are and the staffing issues, processing samples, like multiple samples at the same time, you can do, like, mistakes can happen. And I think the simplest one of them is actually mislabeling a plate, which obviously creates a huge issue, because in this case you've got an unexpected organism in someone with like a respiratory tract infection, which can then obviously change the clinical management, because, as you've rightly said, could put them on the incorrect antibiotic. At the same time, it could just trigger thinking about, oh, do we have another source of infection, and clinically this doesn't fit in. So it's just really, I think it's mainly time pressure, and maybe lack of checking processes in place.
Is this a common thing that can happen in labs in your experience?
It's not common, but it does happen.
Okay.
You do see it sometimes. I mean, I've only seen it once when I worked before, and I think at the time it was seen as a typing error, basically, and therefore the way they put into place is automated labels to come up, and then basically everything is labeled at the same time. And then the sample, you finish processing one sample and then move on to the other to try and avoid these errors. Right.
And has that automated labelling system, has that actually helped to eradicate this sort of issue happening?
Yes, on like further audits of the work, yes, the error hasn't been seen. To be honest, it's not a common error to start with, but it does happen.
Okay. And you mentioned this issue about sort of time pressure. Is there a sort of peak time when you get more samples in the lab, is it just variable according to the day?
Interestingly, it's a change over time.
Oh, right, okay.
Which often are the contaminants.
Right.
Because when you have new doctors starting and they haven't practiced taking blood cultures, for example, blood cultures like many times before, then there is more chance of errors happening at the time of taking the samples, and therefore you get more positive blood cultures coming up. So this is around change over time, actually, which.
And that's interesting, because you bring up a good point to the fact that this error is not just in the pathology lab that this could happen. This could be right the way back to the very beginning. And remember, these two patients are very similar presentations with only perhaps the query, the cause, and the date of birth very similar as well. And I know as a junior doctor myself, I've had a very similar situation in an acute medical unit, and it does take you back really when you realise the potential there. So yes, that's a potential issue. What about workforce in labs at the moment? Do you think that's a potential issue for these sort of errors happening?
Yeah, I think definitely is. We've obviously got a shortage in all, well, as we have it in medical specialties, also in health professions as well, including laboratory biomedical scientists. And again, merging of labs and consolidation of laboratories is not helping. So it's a changing of the working environment. So it just puts off biomedical scientists from actually continuing the work. You see issues around retaining staff. So and then we get new staff, which you then have to train from the beginning, and then it just really it's a huge issue. I think we're facing in pathology in general.
Absolutely, and so speaking from a histopathology perspective, I think the latest survey had showed that only 3% of labs in all departments in the whole country have actually got sufficient staff, which is quite worrying. The effects are knock on from that, so increased pressure and time, etc., workload, and that's where it's a hotbed, a seedbed for where errors and mistakes can potentially happen. Is there some sort of SOP or checking procedure that happens in the sort of micro labs to try and prevent these sort of things happening at all?
Some areas they would do double checks. So the person who processes sample would do the initial checks, and then before the sample is actually processed, someone will come and cross-check, make sure that this is for example, blood culture bottle that we're processing. The labels on the blood culture matches the ones on the slides, on the plates, and that helped in some occasions, but actually not necessarily from microbiology, but from experience I heard before in areas like hematology, they've actually found if they do the double checks, it increases the rates of errors sometimes.
Right.
Because one person depends that the first person have already done the appropriate checks and can do mistakes, and then just counter signs when there's actually an error. So it doesn't always work. But
so that shared responsibility can
exactly.
sometimes actually be a detriment in cases. That's interesting. Exactly. And I suppose the other issue is with clinical information on a request form as well. So this junior doctor in this case had wrote query urosepsis and query respiratory sepsis or pneumonia, etc. on the request form. But I suppose in a lot of situations we just get query sepsis, and so we don't know where their query is. So if this result had then been in that context, the consultant microbiologist wouldn't have given it a second thought. So the wrong result would have been communicated to the ward, and then the patient would have been on the wrong antibiotics. So I guess another important point is the more information that pathology departments can receive via the clinical information is actually very valuable in circumstances like this.
We are completely dependent upon what clinicians are putting on forms to help guide what we think it is, and that helps us pick up errors, because if something's not fitting with the clinical, that's a lot of the time when you pick up the error.
That's true. And I think in microbiology we have the advantage is that in most places you have the microbiology ward rounds, especially for bacteremias. So you actually go out to the wards, check the notes, and speak to the clinicians about the patients and find out more information. It actually gives you like a load of more information than you get from the request form, which helps quite a lot. So it does help in a way.
So that clinical contact can actually be quite a good safety net, really, just to double check that things are what you think they are based on
Exactly.
the
Because when you have conversations over the phone, it's like a lot of the time what you've actually have advised isn't what have been transcribed into the notes, just because of you're expecting a certain level of knowledge to the clinicians you're talking to, which they might not have. They might be junior doctors that just starting. So having actually presence on the ward helps quite a lot.
And thinking about the work environment in general in these labs, is there any other things that can sort of potentially increase the risk of these sort of errors happening, do you think? Are there distractions and things that can happen?
Definitely. I mean, especially if you're at the on-call biomedical scientist, you're processing an urgent sample, and then you're actually at the same time receiving phone calls about how the sample's coming in or about different queries. So you can easily get distracted and be stopped in the middle of what you're doing, and then you might come back and then do something completely wrong because you just don't realize where you've stopped, or you miss a step in the preparation or the processing of the sample. So it comes out to the time pressure that you've got and the distractions.
Absolutely, I think we can all relate to that as a F1 and F2 doctors of being on call, where you have a jobs list that's extremely long and you're doing one thing, and then an emergency situation or something else, or someone phones you from the lab about a blood result, etc. There are lots of things to distract you from what was the original intent, and as distraction is a key thing to potentially leading to errors and mistakes happening. What are sort of the learning points do we think from this case that can be taken from it to sort of prevent this sort of thing happening in the future, do you think?
I think a good outcome here is that actually the patients did not come to harm, because you've had two clearly different presentations, both with sepsis, but different site of infection, and because of the mismatch with the results that you expect to see, the error was picked up. So I think the way the situation was managed quite well. The consultant was there and actually realized that there may be an error. The samples were checked and then the error was identified. So I think a good learning outcome is that you've got the appropriate experience, which actually helps with identifying these errors, which might in many cases just pass and you never realize that there was an error to start with.
Absolutely, and I think one of the other things that's important to stress is that with this is that there shouldn't be any sort of shaking of the heads or this is a bad situation, or attaching blame to this, because no one sets out for a mistake like this to happen. It just exactly, and this can happen. We can all envisage any sort of situation where this can happen, and it will happen to every doctor in their, or anybody working in pathology in their career at some point. But it's about trying to find mechanisms to learn from these things. And certainly the other thing about having SOPs and checking procedures is that sometimes they may not actually be actually usable in a way. Yes. And people have to actually, in the circumstances, perhaps like you say with an on-call situation where you're under time pressure, you have to find a better way of adapting that to actually make a SOP work for you. But that's not necessarily a bad thing. It's actually that information can be used to actually restructure or redevelop and redesign an SOP to actually make it more usable for the future, really. So those are important things that can be derived from it.
It's important that we discuss these things when they occur so that we can learn from it and so that we can build into things like SOPs and alter
Absolutely.
things.
And I think one of the other things is about reporting these things, and reporting incidents like this that have happened, because again you could very easily see this just sort of been shoved away and not discussed and things. But actually, it's important that the reports are filled in and these events are alerted to, so that then a whole review of the whole process can happen, and sort of modes of improvement or analysis of different parts of the process can be looked at, and different components can potentially be adapted to help develop in the future. But it's not about blame. It's about ensuring that patient safety is maintained throughout this whole process. Thank you.